All right, good afternoon, everybody. Been a great seminar. Mike Bach, you did a great, this is a very, very informative seminar. I'm looking forward to learning more. I'm new to the Ditron family. I've met many of you, or some of you I know for a long time. Some of you are I've met today. I'm looking forward to meeting more of you guys. So the topic that I was assigned is called the perfect implant. What criteria are needed for success? And so replacing missing teeth is a process or something that's been done. Is this thing connected to this or is it this one? That one, okay. Okay, so we've been replacing missing teeth since the beginning of mankind, right? Vanity and the need for function has, helped mankind to essentially come up with novel ideas to replace teeth. 4,000 years ago in China, they had these bamboo pegs that were found implanted in the jawbone. Around the same time in Egypt, you had ivory teeth that were implanted in jaws and wired in. And over throughout the progress of time, this is in 700th century, this Mayan girl had these seashells in her jaw that seemed to have osseointegrated. Today, in the 2000s, we're doing the exact same thing. We're replacing missing teeth, and there's very different variations over the years of types of implants, from blades, subperiosteals to inducted implants. I often wonder, when humans come back 2,000 years from now, humans coming back and digging up the jawbones of these patients, what they would think, and what they would think of how we replace the teeth today. And so it's a very interesting, because at each time frame, there was the perfect implant, the perfect way or the best way to restore those teeth. Now, today, implant dentistry, implants are highly successful, right? We can extract a single tooth, we had a talk on immediate implant, and replace the tooth, and then follow that patient for 5 to 10 years, and the survival of the success rate for that implant is in the 99%, 97 to 99%. These are systematic reviews published 10, 15 years ago. So for many years, this has been a very successful treatment. If we extract the entire mouth, all the teeth, and replace them with teeth, all on X, full arch restoration, as shown by lots of documentations, at 5 to 10 years, also the survival rate is also 95 to 98%. So you have a protocol for replacing teeth today that is very, very predictable and very, very, very good. So how do we come up and do better than that? The perfect implant. Well, I mean, obviously, implants, we want them, the criteria that we want them to be biocompatible. We want them to osseointegrate, strong material, surface texture, size, connection, and of course, long-term tissue and bone stability. How do we beat that? Well, there's, in the beginning of our meeting today, only Jen said that how do you change or revolute or an industry that is highly competitive? Well, you have to look at what is needed. We may have a very good implant and very good treatment protocol, but we still have the problem. And that problem that Olga mentioned this morning is diseased implants. Even though our implants are highly integrated and highly successful, they still have bone stability problems and peri-implant disease. So I'm going to focus today on some of these implant factors and protocols and implementation on how to prevent this in the time that I have. So I want to mention about peri-implant disease. Well, how bad is this problem? Well, the problem is actually very, 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 the prevalence is higher than we, really were knew early on. So, when Zitman reported this in 2008, he reported about a quarter to half of the patients had periimplantitis after a certain period of time. Mominatier out of New Zealand published a systematic review 2012, and he said that looking at patients at 5 years, their incidence is reported at 10%, right? So at 5 years. Now, Birch reported at 9 years that the incidence was 15%. And these are cases with severe peri-implant disease, as defined by bone loss that is greater than 3 millimeters and separates. And that up to 45% of these patients have this, at least 2 millimeters or mild to moderate bone loss. Now, it depends on the setting also. In this particular study that was recently published in 2019 out of a major dental university in the United States, found that at 2 years, a third of the patients had periimplantitis. And 1 in 5 at 2 years had problems. So now here we have the perfect implant. We have really nice implant designs and protocols and treatment protocols, yet when we replace these teeth, there's a subset of these patients that have a problem. And so how can we do better? What about full arch? I said that in the beginning that when we take these full arch cases and we edentulate them and replace them with teeth, what's the problem? What's the disease rate with those implants? Well, when you look at full arch prosthesis, systematic reviews, and this was a study that was recently published, 2021, in the Journal of Prosthodontics, and they looked at 18 studies. Now, many of these are the studies that I showed you from the beginning, where they documented these cases for 10 years and then a 98% success rate. Well, what's the prevalence of periimplantitis in this population? Well, it turns out it's about a third of those patients within a 5-year period, 5 to 10 years, excuse me, will have periimplantitis, and also a fifth of those patients. So I often say this. I often say that, you know, we have these patients that come in with failing teeth. We call them a terminal dentition. We extract all their teeth and we replace them with implants. And then within 5 to 10 years, a third of them have the same problem, but worse. But we call that a success. It's a kind of a weird, you know, how do contrast. So you have to remember that some of these patients lose teeth for a reason. Some of them have risk factors. And so what are those risk factors? Well, we know that there are patient factors, two really main risk groups, that two main risk factors, and one is the patient factor, right? The cluster effect, and we already know some of those. That was listed earlier today, and just, you know, so the you can see them on there. And then there are implant factors. In other words, these are local factors related to either the site or the implant itself, the implant type, connection, prosthetic design, the surface, dimensions of the implant, and the location. And so we'll spend a lot of time talking about these implant factors and how they may affect this bone stability and the progression of disease. Well, how do we know that there are such things as patient factors? Well, there's a phenomenon called cluster failures. In any kind of treatment intervention, orthopedic surgery, cardiac surgery, any kind of surgery you have, there's a cluster of patients that have problems. Luckily, it's a small cluster. In other words, you know, when in implant patients, more than one implant fails per patient. When you look at the studies, what you find is that 1/3 of the patients have 2/3 of the problems, the failures. One study looked and found that 5% of the patients account for 57% of the problems. That's the cluster. So you want to know how to get rid of problems and headaches in your practice? It's not about the implant, get rid of the patients. Just you're only going to get rid of 5% of your patients, and you eliminate 60%, 70, 57% of your practice. Not everybody needs an implant, right? So that's the cluster. Now, some of these clusters, it's important to know the risk factors if we're going to try to address the problem, right? So we already talked about the history of periodontitis, and this morning Oli said that even restoring Kumar in 2018 reported that even if when you place a crown and there's a tooth in the mouth, near the area that has periodontitis that's untreated, the risk of that patient, that implant develop periodontitis is 4 times greater. The odds ratio is 4 times greater. Significant. And just having the history itself, take all the teeth out. If they have a history, they have 2.5 times more risk of developing the disease. And of course, if they're not maintained and there's no maintenance therapy, that's also a problem. And of course, you know, we know smoking is a problem, and it's not just smoking, it's just how much you smoke. So some of these patients, is there a way to, or implants or design that we can use maybe to address these patients? So really the risk factors is more than 10 cigarettes. If you smoke less than 10 cigarettes, the risk ratio is about 1.3, which is essentially a minimal risk, right? 1 is no risk. 1.3 is less than 10 cigarettes. So 5, 10 cigarettes, they're going to do okay. But start to get to 10 to 20, the risk ratio starts to go to 1.5, and then a pack a day is 2.5 times the risk. Same thing with diabetes. You know, there's, having high sugar is 3.5 times to 3 times more risk of developing disease. Now, the problem with smoking and diabetes and a lot of these risk factors is that you can smoke 10 packs a day. You have to remember one thing. It's plaque that's the etiology. It's the biofilm that Oli talked about. It is the biofilm that is the cause of peri-implant disease. You can smoke 10 packs a day, but have no biofilm, you have no disease. In other words, you know, a lot of these problems, it's not a matter of if for some of these patients, it's a matter of when. It's just that they have a high inflammatory, a lot of inflammation markers, but if there's not a piece of food or a piece of plaque, there's no disease. In other words, when you smoke or you have sugar running high, you have a bunch of inflammatory markers. There's a bunch of pit bulls running around with guns. When you drop that piece of food, it's when these pit bulls overreact and cause the problem. So it's important to know this, because later on when we talk about implants. So what about site factors and local factors? Well, one of the things is that there's also high risk for a particular site, right? Back of the jaw, front of the jaw, posterior maxilla. For example, this particular patient that I had, I didn't treat her, but she came in and she had implants that continually failed in the lower right quadrant. You can see the Swiss cheese in her jaw. She was referred to me to get implants on the top, and the prosthodontist said, well, while you're at it, can you place an implant back on the right side again? And it had been done multiple times and it failed. The evidence for this is that in some of these patients, they have implants in other areas that are highly successful, but yet repeatedly fail in that one area. Meaning that there's something wrong with that bone in that area or that site or the soft tissue quality. So I grafted the maxilla. Then I placed an implant again back in the right side. And by the time it was, I put the implant on the top and it was restored after about a year, failed again on that right side. So not wanting to give up, I took the implant out, I placed another one in a different site. And again, it failed. But this time, because we have drilled so many holes, there's so much Swiss cheese in the jaw, and the bone that regenerated is essentially poor quality bone, the patient developed osteomyelitis. And you can see from the CT scan there that the bone had completely rotted from the top all the way to the bottom. And and now the patient was on to developing a fistula through that in the neck there. So imagine telling a patient that we're going to resect her jaw for an implant. So sometimes, these are site issues. We were able to treat her with long-term IV antibiotics and debridement without resecting her jaw. Other evidence for site factors, other than the cluster failures, the site failure, is that when you go back and you look at implants that are replacing failed implants, what you find is that they're a lot lower. In other words, when you take out implants that have failed and place it back in that same area, success rate's a lot lower than the 98% that we talked about. They're about in the 70s and 80s. In a study that we published in 2020, we looked at a large sample of patients, 5,000 patients. And what we did was we looked at implants that had failed and that we went back and replaced the implant. But not just one time, we did it 4 different times. I mean, if we found them a second time, a third time, a fourth time for those that had failed. And what we found is that out of 5,200 patients, the initial success rate was 95%. So when we placed implants, 5,000 of those patients, 95% of them, the implants took, 5% failed. Of that 5%, we went and we placed an implant into that site again. What we found was that the success rate was a lot lower in that group of patients. So, and in that particular site, it was 62%, 77%, and then we kept on trying in the ones, and 73%, and then of course 50%, those that wanted to try. So it's replacing implants in this area, in that site, was not as successful. So there's evidence for two types of failure: the cluster failure that I told you about with patients, and the site failure, that site factors. If you go back to that same site, it failed. So why is that? Well, what are some of the local factors when we start to get into the implant factors? Well, there's some emerging, papers and concepts that are coming out. One is this paper that was published by Fretworth, and the title is metal particle release associated with inflammation and peri-implantitis? So there's a local factor. Is it possible that the metals that are coming out that are being leached either through connection, wear and tear, fretting, the cause of some of these inflammatory, or even creating this inflammatory reaction? Remember I told you about smoking, creating these pit bulls, or titanium fretting or particles creating phagocytes, macrophages that are now producing high cytokine levels that are now attacking the bone. And so in this particular, I don't know if any of you've ever, whenever I remove an implant and I take a burr to it, and then you see those particles around the bone, and I try to do a bone graft, it almost inevitably fails most of the time. Versus if I took it out and there was no metal particles on there. So, but I think the titanium particles are highly inflammatory. And this other study, there's this other study that by Peterson, what they did is they took 15 patients that had implants for 10 years that had peri-implantitis. And what they found was that in those patients, there was a high level of inflammatory markers around around those sites. And the last study was published in the Journal of Oral Surgery by Stolzer. This was a control study. They had 3 groups, they had 60 patients, each divided into 20. The control group had no implants. And then there were 2 groups that had implants, also 20 each. 20 with peri-implantitis and 20 without. So that a control with no implants, and then another 20 with implants, but some had disease and the other 20 didn't have disease. And what they wanted to do is they did what's called a titanium challenge test. So the challenge test is that when macrophages gobble up these titanium particles, they secrete cytokines and inflammatory markers. And what I wanted to see is that among these group of patients, which one had a positive titanium challenge? In other words, they had a reaction to or they had a higher inflammatory marker. And they found that the group that 50% of the statistically significant amount of patients that had peri-implant disease had these cytokines. In other words, the macrophages really reacted to the titanium particles. Versus the group that had peri-implantitis was only 3%. So it was very statistically significant. Now, what about the surface of the implant? Could that be also, when you choose an implant and local factors, could that be also a risk factor for developing implant problems? Well, we used to, have machine surface implants. This morning, Cochran talked about the collar, the tissue level implant, the hybrid implant. What about the surface? This is a little bit difficult to prove clinically, but in animals, preclinical studies, it's very clear cut. So what they, Cochran in 2012 did is they took dogs they compared teeth, machine surface, and then rough surface, moderately rough surface implants. They tied a ligature around them. So they tied a ligature around the teeth, which of course created plaque, inflammatory reaction, and bone loss. And the bone loss was 1.7 millimeters. When they removed the ligature, the bone loss stabilized. There was no more bone loss. Now with machine surface, they tied the ligature, they had about 3 millimeters, about 2.6 millimeters of bone loss. When they removed the ligature, some of the bone actually came back. So so when they did histo, the bone loss was only 2.4. So it was able to regenerate some of that, remineralize some of that bone back. Now, when they did that with texture surface implant, they tied the ligature, there was more bone loss, but then when they removed the ligature, the bone loss continued. And so is the presence of a rough surface a risk factor for the progression of disease? Hard to do that kind of study in humans. So what are other local site factors? What about implant factors? Well, the implant, positioning of the implant is a critical factor. And I already talked today, this morning about, the clinician, iatrogenic factor. The way that implants evolved over the years is that you remember in the old days, we placed the implant supercrestal, right? Piatelli in 2003 did a comparison and found that if you placed the implant above the bone, you had less bone loss. If you placed the implant at the bone, you had more bone loss. But in 2010, fast forward with evolution of implant design to bone level type platform switched implant, crestal placement resulted in 2 millimeters of bone loss, but subcrestal placement resulted in only 0.6 millimeters of bone loss. So it's a paradigm shift over just a 20-year period. And so the selection of implant design and implant can cause bone loss. Now, what are the changes here? Well, it's because when we went from a flat-on-flat connection or a machine collar where the gap was seen at the bone, just like David Cochran said this morning, to now where with platform switching, the bone loss has decreased. And in fact, Tom Linkevicius did a study in I'm going to skip that. With Tom Linkevicius' study in 2009 found that when you make that incision, right, and if the tissue is 3 millimeters thick, there's no bone loss. But if it's less than 2 millimeters, there's significant bone loss. In other words, tissue thickness had a significant role in the amount of bone loss. But if the tissue was thin, so the very common mistake, is that a lot of people, if they cut it and the tissue is thin, you place it there at bone, you will have bone loss. So because of this study, what he recommended was do a connective tissue graft or place the implant deeper. So now you've got this connection that's placed inside the bone. So this is a follow-up by this other study. So he said, well, if you place it deeper, so he took the implants and he placed these implants deeper inside the bone. But in thin patients, in patients that had thin tissue. And he compared this to a control group where the implants were of matching connection, but placed supercrestal, so they're placed outside the bone. And what he found was that when tissue was thin, so he concluded that when the tissue was thin, even when you place it deep, you still have more bone loss than if the tissue was thick. But what's interesting is that he couldn't really explain for why other studies found different results. They didn't find this result. Other folks didn't find this result. So what did he conclude? We concluded that it is the connection of the implant that was used in this study, that an unstable healing implant abutment connection during the 2 months of healing. Now remember, this was only based on 2 months follow-up. There was no loading. It was just the abutment. That it's the unstable connection that resulted in this bone loss. Interesting. Very interesting. So here is an example of such. I've done this many times. I take off a tooth, I place an implant, and I screw down the abutment, and it's tight. And I think it's in, but it's just, and Oral said that the eye can see 100 microns. If you can see a gap, that's at least 100 microns. Well, you can definitely see a gap that's open. Well, I didn't know that. I took an x-ray, but I didn't see it. Normally, my girls know to tell me, hey, Bach, you're not seated. But I didn't see it. It was, and of course, that immediately results in bacteria and bone loss. Patient goes to get it restored, bone loss continues, and this leads to an implant failure. I wonder how many peri-implantitis cases started with just that connection. That just having a loose abutment on there, often you will see this. That's why having a loose crown inside the bone is a problem. So the connection is extremely important. So I told you that other studies did not find what Tom Linkevicius found. They found that if you place, so this study was a split mouth study, patients that had 2 implants for locators. So it's the same protoplasm, same patient, they place 2 implants. But one would place it at crest, and the other one would place it 2 millimeters below the crest, but with a tight conical connection. And what did they find? The one that they placed deep inside the bone had no bone loss because the connection was a lot tighter. So the connection, so the one where they place it at the crest had 10 times the amount of bone loss than the one that was placed inside the bone. So this speaks to the connection, the stability connection that we talked about this morning. And this other study here that every implant system has a different type of connection. Michelle Coughlin did this study where they took 6 types of very common connections. They took an internal, like a friction fit, which is the first one. The second is the conical, the Straumann type of fit. The third one was a bi-horizon fit. The fourth one was an Ostrow fit. The fifth one, the E, is a Nobel active. And of course, the other one is a trilobe connection. And so you can see, and what they did is they put those connections under rotational, vertical, and horizontal forces, and also pull-out strength of the abutments. And what they found, if you look on the, is the one that had essentially the internal hex, we call a friction fit, where there's a bubble in there, that had actually under loading had the least amount of micro mobility, and actually about 3 microns. All the other ones, and the CrossFit, which is the conical CrossFit, was about 4 microns. Everything else was up to 8 to 16 microns under severe strain and stress and pull out. So this is, I think, very important. In selecting an implant, you've got to know what type of micro gap, what type, and how it performs under function. This is an interesting study that looked at infecting an implant after placement. There was a rat study where the implants were placed, and then they infected the implant with Porphyromonas and Fusobacteria. They injected the implants early and then late. So early was 21 days after the placement, and late was 32 days. And then they looked at the survival of the implant and the bone loss. This just goes to show you, of course, these are preclinical studies that we can't really do in humans, but you can kind of see what the effects of that, of just having that bacteria there is that if you put bacteria into the site where you place an implant, that a good chunk of that you have a 25% failure rate compared to a delayed infection. In other words, once the implant starts to integrate, you put bacteria there, you don't have any implants fail. So that it is the bacteria that is a significant etiology for implant failure. And then when we look at bone loss, when you put bacteria into these sites, early or late, you're going to have bone loss. So bacteria at that gap is going to result in an implant that will have bone loss. That's why I think that the precision connection with Ditron at 0.5 microns is very impressive. It's something that is going to prevent the bacteria, because the largest, I think, bacteria is about 2 microns. And at 0.5 micron, again, it's very impressive. Now, I like to place my implant flapless. I like to, probably 80 to 90% of the implants I place, I make a little nick in the gum, I push the gum out of the way, and I insert the implant through. And like some of the other speakers, I never punch the tissue. So I make a little nick, and I flapless place the implant, I push the keratinized tissue out of the way. But the one problem with doing that is sometimes I don't see when I put on the healing abutment. So I always recommend that after you do, take an x-ray to make sure that your abutment is fully seated, because just because you think it is and it isn't, you will have bone loss. So when I see a slight opening, go about, tighten it down. Now in the mandible, I do the same thing. Make a little nick in the gum. I push the tissue out of the way. And one of the differences on the mandible, you can often have saliva. When you do flapless surgery in the mandible and you stick that implant in and you hit the tissue first, and there's a bunch of bacteria there, now you're driving that implant and all that bacteria to that rough surface inside the implant. So you can see wet the implant, and you can see it's flooded with water, so that the first thing that the implant touches is not bacteria. Now, implant depth is also associated with tissue thickness. I often say, implant tissue thickness is thick in both vertical and horizontal. Horizontal thickness of tissue is dependent on horizontal thickness of bone. Vertical thickness of tissue is dependent on vertical thickness of how deep the implant is. It's all related to implant position and very little to do with biotype. I know this may sound controversial, but it isn't. So if you want thick vertical soft tissue, you have to place the implant deep. So look, this is a case I did in 2006. I placed an implant supracrestal, crestal, and subcrestal. And you can see the soft tissue thickness. Which one soft, soft tissue thickness should be at least 3 millimeters. Well, why is it there's different soft tissue thickness? It's dependent on implant position entirely, the vertical thickness. So when I place implants, I make sure that I place it deep, at least 4 millimeters, 3 to 4 millimeters, and I always place the widest healing abutment to push that tissue out of the way. And if it's not seated like that, I take an x-ray, I go back and I tighten it down. The healing abutment is going to tell me the thickness. I said that tissue thickness is dependent on implant position. Now, positioning, and I've always had an interest in this because I've always argued that, it's the position of the implant that dictates the tissue thickness. In this study, were patients that had 2 implants, we looked at the angulation of the implants. And what we found is that implants angulation has significant correlation with tissue thickness. So if you have an implant, the same patient that's either placed buccal, through incisal, or cingulum, there's going to be different tissue thickness. And so we did that, we measured and we did statistical analysis. And what we found is that if an implant goes through the buccal, the tissue is about 1.5 millimeters. But in that same patient, if it goes out the cingulum, it's double. It's 3 millimeters in the same patient. Same thing in this animal study, placing implants in the center, the palatal or the buccal, that the palatal placement had thicker bone, but also had thicker soft tissue. And this was a controlled animal study. Now, Levine also showed the same thing, that when you place implants towards the buccal, the gaps have a propensity to fill in. We also showed that when you have thick crestal bone, you have a direct correlation with thick crestal soft tissue. Well, how does that apply? Well, if you look at here, I placed 2 implants. One I placed with a guide back 20 years ago. I placed this one around that time when we were using these guides. I placed the one on the left flapless through a guide that the dentist gave me, and then I raised the flap and I placed it. And because I was just 0.5 millimeter off, you can see one implant's a little too buccal based on the guide. And just based on that, you can see what it did to the soft tissue. You can see that the tissue on the left was much thicker. The keratinized tissue is robust, thick, and full, whereas the one on the right is thin. All because I was 0.5 millimeter off. In the small spaces, it can have a profound effect on your tissue thickness. And this is how you follow the patient. You can see now the one on the right is going to need a soft tissue graft, whereas the left doesn't need one. It's completely, the tissue thickness dependent entirely on implant position. Here's another patient. Bridge came off because the screw broke, because the connection was weak. Took off, I didn't place the implants, but I took the screw off, put the bridge back on. And you can see the profound effect of just the position of the implant. In this particular patient had plenty of keratinized tissue. Patient also had plenty of bone, because on CT scan, you can see the bone on the crest of the implant. Whenever you can see a bone on the crest of the implant, that means there's a lot of bone. This is entirely positioning of the implant. It's not mucosa that's there. The tissue is thick, and there is bone. But just because the implant is just a little bit buccal, what you see is how it affects the soft tissue, how it affects the length of the restoration. So what I did, I told the patient, I can actually help you. I removed the implant and I repositioned it. So I re-angulated the implants towards the cingulum. I placed it towards the buccal by about 1 millimeter. And just by doing that alone, nothing else, the harmony of the soft tissue came back. You can see the CT before and after. All I did was just re-angulate just slightly. It harmonized, it balanced all the soft tissue margin. Just a few years later, porcelain chipped on that, but you see how it harmonized the soft tissue. So now this is why I like this design, the ultimate design by Dytron, because this concept of bone platform switching that Matteo Danza came up with, where essentially you see a reverse neck, concave neck, where this crestal bone reverses. So essentially what it's doing is re-angling the implant for me and putting the implant 1 millimeter back. or how, depending on the size of the implant, obviously, for me. Therefore, thickening the volume of bone and thickening the soft tissue. So when I go to look at this type of the design, you see what it does is that in this particular case, what I did is all I did was just reposition about 1 millimeter. And if you're using a 4.2 diameter implant, essentially what you're getting is about, so based on the study that they showed, was that essentially you're getting about 1 millimeter ring of bone around the implant, an extra millimeter of bone. That translates to another millimeter of soft tissue thickness. So implant design is critical. Here's another case where I took out a tooth. There's one implant that was already there. I placed the second implant to the immediate molar, and you can see that by having that extra ring of bone increases the intercrustal bone thickness between the implant. Anyway, bone is like money. The more money, the better. So having more of that bone there is extremely critical. That bone platform switching is that. And then implant size. So we talked about, the connection and the bacteria. Implant size is extremely critical. We've evolved also over the years. In 2006, Arojo, who I just lectured with in LA this past weekend, did the study, and he found that if you place a 4.1 diameter implant into a dog, you get into a socket, you get about 2 millimeters of vertical bone loss. But if you did the same, in 2010, Covani did the exact same study, but what he did is he decreased the diameter of the implant to 3.25 millimeters, just by 0.8 millimeters. What he found was that the bone loss dropped to 0.8 millimeters. In other words, the smaller implant had less bone loss, and that the wider one encroached more on bone loss. Now, there are studies that show that implants in the anterior mandible, that narrow diameter implants have higher failure rates. It's not because of loading. It's because when you use a narrow diameter implant, it's often in areas of thin bone. And so in areas of thin bone, you really don't have a lot of money. So the risk of losing that money is very, very easy, right? And the implant fails. But conversely, wide implants also have higher failure rate. This is Momi Anate, the guy that I quoted earlier. In 2000, I think it was 11, I was lecturing in Australia at the New Zealand Australia Academy of Osteointegration, and he was getting his PhD. And he went to all the company and he asked them, hey, if you give me all the wide implants, this is back in those days when they just started coming out with the Fat Boys, the 7 implants, all the Megagens and all the big implants. So, it was considered to be probably a good thing. So he went to all these groups and he did this PhD on this study. And what he found was that the conclusion was completely opposite. That for every millimeter that you increase the diameter of the implant past 5 millimeters, the rate of biologic peri-implant problems goes up. I just saw him. He came. I gave a lecture at the AAP in Austin just a month or 2 months ago. I mean, of all things, I asked an oral surgeon to give a lecture on peri-implantitis at the AAP meeting. But and Momi Anate was there. So 15 years has passed. Then, so implant diameter, there's now implant length. Grafting is always not a great, is not always predictable, especially vertical augmentation, as we know, right? Grafting is fraught with complications. I do a lot of grafting. I'm not against grafting, but when you can avoid it, you should. Right? Systematic reviews have shown that if you had to do any kind of vertical grafting versus placing a shorter implant, you should always choose the short implant if the patient accepts it. So systematic reviews from 15 years ago and meta-analysis of randomized controlled studies showed that. And fast forward, 10 years, same thing, that grafting short implants work better. In fact, the 4 millimeter ultra short implant versus, as a randomized controlled versus placing a longer implant in grafted bone showed that the short implant had better bone. Had better bone, there was no difference in outcome. Now this then leads us to the next topic, is that when you choose an implant, when you place this ultra short implant, you essentially have a big crown. So the crown implant ratio now becomes a factor. How do you choose? Should you choose a short or long implant? Well, this has been known for years, that crown to implant ratio, that teeth is not implant. You can have the teeth, it's 1-to-1, but with implants, it could be 4-to-1. And it does not affect the crestal bone. So 2009, they found that the systematic review back then says that the current literature shows that crown implant ratio does not influence bone loss, does not cause bone loss. 2022 found the same thing. In fact, what they found was that increasing the crown to implant ratio decreased the amount of bone loss. Completely a paradigm shift. How is it that you increase the crown, you get better bone? Well, that's very interesting. Well, this is how about grafting? Comparing a ultra short, meaning nowadays short implant is not 8 anymore. Ultra short is less than 6, and a short is confined as 6 to 8. So what they did is they compared an ultra short implant compared to doing an osteotome sinus lift, a 10 millimeter with sinus. There's a randomized control study also. What they found is when you do an osteotome lift and you place the longer implant, you have more bone loss. This is statistically significant. Ultra short implants was less discomfort, but had less marginal bone loss. There's another one. This is a systematic review that confirmed what that study showed, was that placing implants less than 8 millimeters compared to greater than 8 millimeters with a lateral window sinus lift. So placing a short versus a long with a lateral window sinus lift. And what they found, this is based just on 3 randomized control studies, so you have to take it with a, what they found was the longer implant had more bone loss, when the short implants had less bone loss. So this then speaks to the fact that this grafting is associated with bone loss. Yes, this study here looked at, by Pablo Galindo Moreno, the best model to look at for bone loss and grafting is that when you do a graft in the sinus, split mouth model, right? On the one side, you place an implant and you graft. The other side, you place an implant. You graft first, and then you place the implant, right? Easy to find out. And what did they find? That when you do simultaneous implant placement, the graft shrinks. So grafting is always associated with bone loss. And so what they found, so here, this is my case. You can see I placed a simultaneous graft with the implant, and after, there's no loading, the implant was submerged. But yet after 4 months, there's already 2-3 millimeters of bone loss. Of course, this will lead to periimplantitis. So I removed the implant and replaced it. And then this other study, what they did is they looked at staging augmentation. So same model, split mouth type of model in the sinus. 2 studies were done. One is a 5-year prospective study, and another multi-center study. These are all recent articles. What they did was they looked at when you graft in a stage fashion, you had less bone loss and less periimplantitis. So one stage augmentation significantly correlated with that. So if you do it simultaneously, I hear a lot of people, trying to speed up the timing. But when you graft and you place implant, you have more bone loss and you have more periimplantitis. However, if you stage it, it had less. 2 different studies showing that. So why is that? Well, so in situations like this, where if I'm going to graft or I'm going to place a short implant, I'm going to place a short implant. I'm going to place an the short implant in the site, flapless. So why is it that the short implants perform better? This is maybe may provide some insight into this. This was a randomized control study. After 5 years, they looked at short implants versus long implants, and they looked at radiograph density around the implant at 5 years. So a 6 millimeter group and a 10 millimeter group. And what they found after 5 years was that the short implant had more radiographic density, which is interesting. But the long implant had lots of density. They got darker, whereas the short implants got whiter. And that the only thing that was correlated that showed correlated with that was the crown to implant ratio. The higher the crown to implant ratio, the more the bone. Again, this is a paradigm shift in the way we think. So here's a case, I've got, a lot of times you don't even need graft. This patient was referred to me. Have you ever seen the American Association of Oral Maxillofacial Surgery defines the severely atrophic mandible as a mandible less than 10 millimeters. This is a 3 millimeter mandible. Have you ever seen a 3 millimeter mandible in the posterior mandible? A mandible prone to fracture. So I was referred and asked to put, you can see it's completely all hollowed out and shelled out. Now, so to graft, but really, the patient doesn't need a graft. So of course I grafted the maxilla, but in the mandible, I'm going to place the shortest implant I can. And in fact, I placed, what you see is that we just make a little nick in the gum, almost like flapless. And I just placed 4 implants, I sutured. I did nothing else, and then immediately load the implants. And you can see that after only 8 months, 10 months of loading, the mandible tripled in size to 10 and 8 millimeters. In other words, loading short implants progressively improves the quality of the bone. This is after 1 year. So and then of course, sometimes you need to splint these implants, and when they're short, but there is no evidence that splinting improves the ability of implants. However, splinting increases the risk of peri-implantitis. So there's been a number of studies that have shown this, that when you have implants that are adjacent implants that are splinted, I heard on the panel that somebody was saying, well, just place some implants, more implants. That's not the answer. The risk factor for peri-implantitis is more implants. So the more implants you have and the more that they're splinted to each other, the more problems you're going to have. In the studies, it's convincingly shows that. Splinting versus non-splinting, the splinted implants, 45% of them develop peri-implantitis. The non-splinted one, only 25%. And this is a systematic review on splinting and non-splinting. There's 2 of them, and they both concluded that splinting offered no benefit in survival of the implants. And so I want to skip this. I just and so lastly, I just want to give me 2 minutes here, is we talked about bone level and tissue level implants. Anecdotally, we've seen this for many years. You see people with rip-roaring periodontal disease, like this guy coming in, and he's got, partially done, he's got some implants. But the ones that are doing really well, the guy that's got rip-roaring periodontitis, the tissue level implants are doing fine, whereas the bone loss is going on everywhere else. And we've seen this, and the evidence seems to show that putting that gap away from the bone and a polished collar may be the better way to go in terms of choosing implant. And so Fu, in 2000, concluded that, in high-risk patients that have periodontal disease, putting that type of implant may be better. Also, that when you, putting the connection higher decreases the crown to implant ratio, and also decreases, and the white weakness of it increases the support. In periodontally compromised patients, placing a tissue level implant has significantly less bone loss than that of bone level, from 1.3 versus 0.2 millimeters. And then, and lastly, you have to remember one thing, is that patients are ever evolving. You don't get, the patient doesn't not come to you at 30 and have, they may be healthy, but at 50, just like we said, they start to develop disease, or 60, they stop brushing their teeth and they have diabetes. So you have to remember that one, so a lot of times you say, well, I'm going to place a tissue level, but only in periodontally compromised patient, or I'm going to do this, choose this implant versus that implant. Patients are ever evolving. So I treat patients as like an orthopedic appliance. I tell them that some of you're going to need to replace within 15 years, and I'm going to be, and that I see that they are ever evolving human beings. And so sometimes it's better just to keep their teeth rather than extracting them and putting implants, as this study showed. This study showed, the systematic view showed that you follow patients with terminal dentition, and they follow patients that had their teeth removed and put implants in. And after 5 years, what they found was that the patient with the terminal dentition, where they kept the teeth, still had their teeth. So the conclusion is that, the etiology, I talked about, the perfect implant. Is there such thing as a perfect implant? It's really the perfect situation and implementing it in the right patient. So the etiologies of failures and peri-implantitis is multifactorial, and the interplay of these factors that I told you about, patient factors, implant factors, and the progression of disease plays a pivotal in progression of disease. Remember that replacement therapy is not as successful. Whatever treatment you do, you have to think 5, 10, 20 years. And that choosing an appropriate implant design and connection that suits the specific clinical scenario is a critical factor for implant success. So I'm sorry I went over. Thank you so much.